touch briefly on distal clavicular osteolysis prior as a differential diagnosis for AC joint pathology or AC joint pain. And this is a condition that you typically will see in patients who are doing a lot of heavy weight lifting or bench pressing more specifically. The etiology of this is thought to be due to repetitive trauma to the distal end of the clavicle, which leads to an inflammatory process leading to microfractures or osteolysis of the distal clavicle. It may be difficult to see, but if you look at the X-ray up above there, you may see a bit of kind of punched out kind of lesions at the end of the clavicle with some sclerosis there as well. And these would be typical findings that you may see on X-rays with patients with distal clavicular osteolysis. Again, the mechanism of injury for this is typically high volume loads and pressing or pushing positions. On an exam, they'll have pain at the distal clavicle, which can mimic AC joint pain. So all your typical AC joint tests may be painful. And again, X-rays may help confirm the diagnosis, but caution that they can be normal in the early stages of this condition. The mainstay of treatment for this is resting from the aggravating activity, so usually laying off of the bench press, shoulder presses for some time until the condition kind of settles. Physio may be helpful in terms of addressing any ongoing shoulder mechanical dysfunctions that could be contributing. Controversial as to whether or not steroid injections are a good way to treat this, especially if you're considering this to be a microfracture process. Potentially, steroids may do more harm than good. I think it's certainly something you can consider in patients who have not responded well to other conservative treatment options. And then finally, you may want to refer these on to your surgical colleagues where distal clavicular excision may be necessary to resolve the condition. We'll move on now and talk about mid-clavicle fractures, which typically most often occur in the middle third of the clavicle, followed by the lateral third and then the medial third. The mechanism of injury typically is a direct blow to the lateral aspect of the shoulder or directly to the clavicle. So you may see this in falls or with direct impact in contact sports, for example. On exam, typically there's an obvious deformity at the fracture site, especially if it's a displaced fracture. You may see some possible accumulations and swelling over the fracture location. And patients presenting with clavicle fractures typically have quite painful and restricted range of movement, with pain generally on the clavicle. Obviously, with the open fractures, you would be concerned about a tension of the skin or potentially an opening of the skin, and those should be managed appropriately. The X-ray is your main modality of investigation to assess in detail the type and location of the fracture. The goal of treatment for most mid-clavicle fractures is to provide pain relief and to allow healing of the clavicle fracture and restore normal shoulder mechanics, especially post-fracture healing. Specifically for mid-third fractures that are less than 100% displaced, there's a debate out there as to whether or not these should be treated surgically or non-surgically. Certainly, I am of the opinion personally that most of these can be treated non-surgically. For fractures that have a greater than 100% displacement, I think considering surgical management may be prudent, especially if there's greater than 1 to 2 centimeter shredding of the clavicle fracture. Medial third clavicle fractures typically managed conservatively as well, especially with anterior displacement of the fracture. Obviously, with posterior displaced fractures, you worry about risk of injury to the neurovascular structures, so those ones may require more surgical solutions and treatment options. Now we'll move on to talk about distal clavicular fractures. These are essentially more rare than the middle clavicle fractures that we previously mentioned. They comprise about 15% of all clavicular fractures, with many involving AC or corticoclavicular ligament injuries as well. Fractures that are medial to the ligaments tend to have a greater degree of displacement and are more prone to delayed union and non-union. And these type of fractures tend to be more common in older patients or those with osteopenia or osteoporosis. The mechanism of injury is similar to those that of the mid-clavicle fracture, and on presentation, investigation modalities are all similar to the previously mentioned mid-clavicle fractures. The differential for distal clavicle fractures is a bit more interesting because in pediatric patients, the medial and distal clavicle physes can be open quite late, up until the age of 25, and so you should always consider physeal injuries with patients presenting with pain at the medial or distal clavicle, especially in the context of normal x-rays. In terms of classification of distal clavicle fractures, which we'll go over in the next slide here, it becomes a bit more complex than the medial clavicle distinctions, and these are kind of grouped into essentially 5 different types. In the first type, the fracture is lateral to the corticoclavicular ligament, as you can see here, and there's very minimal displacement in these types of fractures, and they tend to be stable. In the type 2, 2A specifically, the fracture is medial to the CC ligaments, and so you tend to get more significant displacement and unstable fractures. Type 2B fractures tend to occur between or lateral to the CC ligaments. They tend to again have significant displacement and tend to be unstable as well. Type 3 fractures, as you can see there, are intra-articular fractures that extend to the AC joint. This corticoclavicular ligaments are typically intact, and these are stable fractures. Type 4 fractures are a physeal fracture, essentially, with displacement of the lateral clavicle occurring through the tear in the thick clavicular periosteum. In these cases, the clavicle essentially pulls out of the periosteum, the periosteal sleeve. And then finally, you have the type 5, which are comminuted fractures and are unstable fractures as well. Having gone through the prior classification system for distal clavicle fractures is quite useful when it comes to management. Types 1, 3, and 4 fractures, which are stable fractures, are treated non-surgically with goals of care similar to those of the mid-clavicle fractures previously mentioned. Relative contraindications to surgery in this group would be types 2 and types 5 fractures, which tend to be more unstable fractures. Certainly, absolute indications for surgery would be any impending open fractures, any vascular injuries, or floating shoulder, which is depicted in the picture above, which involves a distal clavicle fracture in association with the scapular neck fracture with significant displacement, typically 1 centimeter or more.